January of 1976, the Latin American Association of Pharmacology held their annual meeting in Panama City, Panama. And Panama City is that red star you see right there in the center of the map. Now, a young assistant professor from Washington State University had been invited to lecture on drug interactions. It was his very first invitation to lecture abroad, and he was very, very excited. There was a drug interaction paper that he usually discussed to demonstrate a common reasoning error in drug interactions, but he had to shorten his lecture at the last minute, so before giving the lecture, he removed that slide that discussed this error. As we will discuss later, this saved him from a very embarrassing situation. Yes, it was me. Greetings, my name is Science-Hansten, and today we will discuss common fallacies and reasoning errors and how to avoid making them. This is part one. I divide the topic into two videos so I could keep them from being too long. By the way, this is allergy season in Santa Rosa, and I have to clear my throat often, so I'll try to turn off the mic when I do that. So if you see a short pause, that's probably what's happening. Now, I will emphasize fallacies in therapeutics and drug interactions, but I'll also use examples from life in general. And keep in mind that there can be considerable overlap, and some of the examples have multiple fallacies going on at the same time. Okay, the first one I'd like to talk about is the post hoc fallacy. Post hoc ergo propter hoc, which means after this, therefore because of this. The classic example of the post hoc fallacy is the rooster taking credit for the dawn. Every morning he wakes up, he crows, and the sun comes up. So pretty soon he thinks he's causing the sun to rise. And it's not just roosters who commit this fallacy, humans do too. We encounter this fallacy frequently in everyday life, but it's a huge problem for drug interaction case reports, especially case reports. So here's an example. Here's a case report from many years ago that demonstrates this fallacy. This was a guy on chronic warfarin therapy. They were monitoring his prothrombin time, which back in those days was used instead of what we use today, the INR that we use today. And he went fishing, and his anticoagulation effect about doubled, came back down, he went fishing again, and there was another doubling of his prothrombin time. So it's pretty clear fishing is contraindicated in people on warfarin. Now, I'll explain that in a minute. Many other drug interaction case reports suffer from this exact same fallacy. And anticoagulants are a particular problem because they fluctuate anyway. And when they fluctuate, people look at what happened right before that and say, aha, that's what caused it. So what could account for the increased warfarin effect in this patient after fishing? Well, I suspect it may have been all that beer he drank while fishing rather than the fishing itself. Large amounts of alcohol can indeed increase warfarin response. Smaller amounts have very little effect, but if you get drunk, that can, in fact, increase the anticoagulant response. But we always have to worry about association versus causation. We've talked about this before in this class, but it's also a common problem for drug interactions. I ran across this problem over and over when writing a review of H2 blocker drug interactions. This was about 25 or 30 years ago. I read every paper ever published on H2 blocker drug interactions, including all the case reports. It was a complete disaster. People were using the Naranjo algorithm, which is commonly used to assess adverse reactions to individual drugs, not drug interactions. So it didn't work, but they used it anyway. But there were many other problems with these case reports. So I proposed a new tool, the Drug Interaction Probability Scale, DIPS. It was based on the Naranjo algorithm, but it was tailored to two drugs, a drug interaction instead of just one drug. But I just had it sitting there in my file, and finally, thank goodness, John Horn, my colleague John Horn, took the initiative, and along with Lingtac, we got it published. Now, if John and Lingtac hadn't pushed it, it would have languished in my file forever. It'd still be sitting there. So thanks to them. Here's another example. Couples, I saw this in a front page of a newspaper several years ago. Couples who live together before marriage are more likely to divorce than couples who do not. The conclusion, of course, is living together before marriage increases the divorce rate. Now, I hope that sounds fishy to you, because people who choose to live together before marriage are probably somewhat different than those who don't. Maybe they're not as opposed to divorce. We don't know, but they clearly could be different. The only way to get a valid result to this question would be to take 1,000, let's say, for argument's sake, 1,000 couples who plan to marry, and then randomly assign them to and force 500 of them to live together and prohibit the other 500 from living together. Then compare the divorce rate. Obviously, this is unethical and it's not going to happen. But this is the only way that we would be able to tell if this is a valid conclusion or not. I suspect it probably is not valid. Here's another example. I just had to clear throat there. I saw this here's another example. And let's go, and this comes from the Panama story. Let's go back to that. The slide I removed at the last minute described this case. It was a 51-year-old man on an anticoagulant who had a fatal bleed after stopping chloral hydrate. They assumed that chloral hydrate was an enzyme inducer like barbiturates. Barbiturates are used as hypnotics, and so because chloral hydrate is also used as a hypnotic, they thought, well, maybe it's an enzyme inducer too. Barbiturates are, so maybe this is. Now, they're completely different molecules. Chloral hydrate's a very simple molecule. You see on the right there, the green are the chlorine atoms. But when I looked at this case, the time course didn't look right. And even worse, very soon, evidence started to appear that showed chloral hydrate increases oral anticoagulant effect, not decreases it. So it's not even an enzyme inducer. And so it wasn't involved in this drug interaction. So usually I use this to show how errors can be made with drug interactions. This is a different fallacy, the fallacy of hasty generalization. But this time I didn't use it. And after my lecture, a physician came up to talk to me. And when I looked at his name badge, I realized that he was the primary author of this paper, the slide I almost showed to demonstrate how people make dumb mistakes in drug interaction case reports. Now, he was a physician at New York University, so who would have guessed he would have been at this symposium? So I dodged a bullet. So Panama City is fairly close to the Panama Canal. You see the little red arrow there. And I had one free day, so I asked the professor who had invited me, who lived there, how to arrange it. And he said, don't go to the Panama Canal. It's just a big, ugly canal. You should go to the San Blas Islands, shown by that arrow on the right. And so it was worth the risk. It was absolutely magical. Oh, before I say that, let me describe the flight. Left Panama in a small plane. The professor made the reservation for me. It was looked pretty dilapidated, and it held about 8 passengers. I got on. I looked up to the front, and there was one pilot. And I looked at the instrument panel, which you could look directly into it while you're sitting there. At least, and I'm not exaggerating here, at least half of the dials and little things were gone, and some of them were dangling by their wires. All these instruments, and the plane otherwise looked pretty bad. So we flew over to the San Blas Islands, landed on a small little island, which I was sure we weren't going to be able to stop before we tumbled into the ocean, but we did. But it was worth the risk. It was absolutely magical. Hundreds of beautiful little islands like this. And some of the Kuna peoples who inhabit some of these islands were dancing to a flute. It was a flute-like instrument. And I can still, this is 50 years later, I can still remember the tune that they played. It's interesting how music can stick with you so long after you hear it only once. By the way, these islands are probably doomed in the next few decades due to sea level rise from climate change, unfortunately. So here's another fallacy, the fallacy of faulty analogy. And that's comparing two things that are similar in some way. They're both fruits, but not similar enough to support the conclusion that's drawn. So a analogy that we see sometimes is that banning guns is as ridiculous as banning cars. Last I checked, deaths from the U.S. in the U.S. from guns was about 48,000 a year. From cars, a little bit less, maybe 40,000 a year, people dying in car accidents. But the problem is that banning cars would cause huge disruption. So they're clearly not the same. We're not going to discuss gun control. It's too political, but gun supporters should use arguments other than this to support their position. Now, another faulty analogy that has almost certainly caused fatalities in thinking let me start that over. Another example that's almost certainly caused fatalities is thinking that drugs that are substrates for a CYP450 enzyme will necessarily inhibit that same enzyme. After all, if many cars are on the highway, they will compete with each other and traffic will slow down. But the flaw in this argument is that often enzyme capacity is large and they can handle many drugs at once, kind of like a highway with 30 lanes in each direction. Now, there are times when competition does happen, so I'm not saying it never happens, but sometimes drug metabolism can slow, causing drug interactions. But this is not guaranteed by any means. You can't assume it. And some people assume that it's just a given that this will occur. It's not. And this fallacy is what caused some of the tamoxifen studies that we talked about earlier to go off the rails. As we see here, this is a study of tamoxifen and 2D6 inhibitors, and they concluded that available studies do not appear to support a negative impact of CYP2D6 inhibitor use on breast cancer recurrence and mortality in women using tamoxifen. Now, when this was published in 2010, I thought, wow, this is not what we would expect given what we know about the pharmacokinetics and the pharmacology of tamoxifen. So I got the paper and I analyzed it for where they might have gone wrong. Sure enough, they committed the highway fallacy. Their list of 2D6 inhibitors included many drugs that were metabolized by 2D6, but almost certainly did not actually inhibit 2D6. So this basically invalidated their results. So yet this paper, like and others like it, that committed the same fallacy are cited to this day as evidence that one need not worry about 2D6 inhibitors in women taking tamoxifen. This is just wrong. And it's almost certain that many women have been harmed and some probably died as a result of this error. Here's another faulty analogy fallacies. This was a faulty analogy fallacy here. Here's another one. And by the way, by Carlo Rovelli. And by the way, Carlo Rovelli is one of my favorite theoretical physicists. I've read a couple of his books, and they are great. He's a wonderful writer. And he's very insightful, one of those scientists who most eloquently supports the value of philosophy in science. So I'm a big fan of Carlo Rovelli, but even your heroes can sometimes stumble. Here's the story he told in one of his books I was reading. He said 4 colleagues at his institute developed a rare non-infectious illness at about the same time, but they could not find a cause. They looked for contamination. They looked for everything that could possibly have caused it, and they couldn't find anything. And some considered working elsewhere. Rovelli told this story to a friend who happened to be a mathematician, and the mathematician just laughed at the story. He said there were 400 tiles on the floor in the room they were in, and if he threw 100 grains of rice on the floor, some tiles would have 4 or more grains, so don't worry. Rovelli, by the way, displays a certain degree of tonsorial neglect, but think of the time he saves combing his hair and getting haircuts. It actually looks pretty good on him. So they tried it several times, and there were indeed always 4 or more rice grains on at least one tile. So the mathematician said, case closed, I've solved it, it's no big deal. So where did these 2 brilliant people go wrong? they didn't understand probability and statistics of the example. This guy was a mathematician, but he probably was not a probability theory expert. But Rovelli took this as proof that the rare illnesses were just random. And so I had to clear my throat again. But does this make sense? It looked fishy to me. I hope it sounds fishy to you. Just thinking of the story without knowing the statistics of it, does that sound reasonable to you? I bet it doesn't. It certainly didn't to me. And everybody I've relayed this story to immediately said, well, that can't be right. And these are people that are not statisticians or not even scientists. So when something doesn't sound right, it's important to investigate it. This is healthy skepticism. Now, it could turn out that it really is right, but at least you ought to look into it. And when I did, and I consulted with experts who are probability experts, this is what I found. First, the European Union defines a rare disease, which is what they called this, as one that occurs in less than 1 in 2,000 people. So that's a fairly low P. With 20 people in the lab, the chance that 4 people have it is a very small P, as you see there, a very low likelihood. That's a chance of about 1 in 3 billion, using the binomial probability formula, which I'm sure you remember from your statistics class. So even if you calculate using 50 people in the lab, it's still unbelievably unlikely that 4 people would have the same rare disease. It would be about 1 in 70 million. That's still not a pretty low likelihood. Even if you increase that all the way up to 100 people in the lab, the chance of this occurring would be 1 in 5 million. So what is 1 in 5 million like? Well, even with 100 people in the lab, it's less likely that if you had a friend who lives in Los Angeles, but you have no idea where she lives, so you just pick a house at random, let's say using a dartboard, and you knock on that door and she answers. That's how likely that is. And it's even less likely because there's only 1.5 million households in Los Angeles. You'd have to expand it to all the neighboring cities as well before you had something comparable. So the tile analogy was clearly not valid. Okay, here's another fallacy. The jury is still out. Sometimes this is the best conclusion, but other times it can cause serious problems. The question is not whether we know for sure. The question is, what is the threshold for action? So the jury still out is saying we are not sure if X is true or false, so we shouldn't act until we know for sure. This can cause a lot of difficulty. So, what is the threshold for action? First of all, the jury is always still out, no matter what the topic. And this argument may be used to justify inaction for drug-drug interactions, and it often is. We don't know for sure, so let's not do anything. But the question is, do we have enough information to require action? That is the question. There's a cancer researcher in France, Jean-Luc Raoul, who's an MD, PhD, works at a cancer institute in France, a very eminent cancer researcher, and he's been fighting this problem for several years. This paper he wrote a few years ago, Prevalence of Proton Pump Inhibitor Use Among Patients with Cancer. And it was still very high. Lots of people on anti-cancer drugs that interact with proton pump inhibitors were still getting PPIs, proton pump inhibitors. And the problem with that is that some of these anti-cancer drugs don't work nearly as well. And the sad part is, in the presence of PPIs, and the sad part is that many of these people don't need to be on PPIs. So there's lots of PPIs, including many that are OTC. So the problem here is that people on these anti-cancer drugs may unknowingly reduce their survival. Here's one study. People on dasatinib for leukemia, and an amazing 21% of them also received PPIs. And those who did receive PPIs had shorter 5-year overall survival. You see that on the right, reduced survival. So those were preventable deaths. Now, some of these people eventually might die anyway, but some of them would probably not. So this is a tragedy, basically. And Jean-Luc was very upset about this because I started emailing with him about this. Here's another study. These are people with a different cancer, the advanced bladder cancer, which is really not a good thing to get. And this is inhibition of atezolizumab efficacy due to PPIs. Look at the left-hand side of this slide. In red are people with advanced bladder cancer who got a atezolizumab in red without PPIs, and you see that their survival is considerably better than in whatever color that is, teal, I'll call it teal, who got atezolizumab with PPIs. So there's a lot of months and actually years, even if you add it all up, of people who survived because they were not on a PPI. Now notice when they compared it to chemotherapy, which would not be expected to be affected by PPIs, and it wasn't. So this clearly shows it's not just the PPI that causes the problem, it's the interaction with, in this case, atezolizumab. And by the way, where are we getting these names? Come on. When I was at UCSF, we had normal names for drugs: aspirin, morphine, cortisone, penicillin, atropine, insulin, thorazine. That's the kind of drugs we had then. Now, look at this. Unbelievable. Atezolizumab and all sorts of other crazy names. Now, if you look at that list, if you're really astute, you will notice that that one is not a drug. He was an Aztec deity. And actually, this one was the largest flying dinosaur. So, but even though I snuck those in there, they look like all the drug names, so you probably didn't notice. Well, maybe those of you that are very astute noticed. But I'm against all these crazy new drug names that they're coming out with. They could figure out how to make them shorter. And by the way, that dinosaur was great. Very cute guy. He was the largest animal ever to fly. He had a 40-foot wingspan, size of a single-engine Cessna 172. And of course, he went extinct with all the other dinosaurs when that asteroid hit the Earth about 66 million years ago. So Jean-Luc enlisted my help with the pharmacological and philosophical aspects of this problem, including the precautionary principle, which is similar to the thing I'd been working with, Pascal's uncertainty principle. It's kind of related to that, and which says basically, if it's easy to avoid a risk, you should try to avoid it, even if the science isn't completely settled. So we published this paper last year to try again to reduce the number of cancer patients being harmed by this drug interaction. I mean, he said, when we first started emailing back and forth, he said, I feel like I'm standing on the top of a mountain screaming and nobody is listening. And even some of his fellow oncologists, some of them, of course, get it and they're doing the right thing. But too many of them were not getting it. And also, other physicians who were not oncologists were prescribing PPIs for patients who were under the care of an oncologist, which makes it even more difficult to solve. And by the way, Jean-Luc and I have become friends during this process, and we still exchange personal emails and talk about global politics and all that kind of thing. That's one of the fun things about working with people in other countries. So here's the cheat sheet, so you don't have to read that article. So on the left side, any proton pump inhibitor, and I listed, I think I got them all, with any of these anti-cancer drugs. Tyrosine kinase inhibitors, CDK4/6 inhibitors, and immune checkpoint inhibitors. For some of these, it's because of increased pH of the gut, because these drugs may require acidity to be absorbed. So it's a very simple interaction. But with others, it's more the immune checkpoint inhibitors. It's probably an effect on the microbiome that's causing it, rather than increased pH of the gut per se. And by the way, H2 blockers and antacids are much less likely to interact because unlike PPIs, they don't last 24 hours and you can space the doses. So if the patient absolutely needs reduced acid in the gut, use one of those. You can get around the interaction if you use a H2 blocker or antacids. Now, sometimes the jury really is still out. I picked this ampule up on my first trip to China in 1985. It was an oral liquid in a glass ampule. I'd never seen that before. But you probably can't read it, so I've told you what's on the label. It says main ingredients: ginseng 50%, frog 30%, and ginseng syrup 20%. Now, it doesn't say what kind of frogs, what parts of the frog, nothing, just frog 30%. So I have no idea how frog might interact with all the medications people take. So if somebody asks me about this one, I have to say, well, the jury really is still out. And this trip was a pharmacy delegation. I was one of the two educational leaders where we visited pharmacies, and my colleague and I gave lectures to some of the pharmacy schools, that kind of thing. And we visited a school where a grammar school, actually, a grade school, where they assigned a student to hold our hands. Okay, by the way, here's one of the pharmacies we visited. But we visited this grade school, and they assigned kindergarten students to hold our hands as we toured around. These are the people in our group, and here I am with my assigned student. They were extremely cute. I still think about that, actually. It's amazing. And this is Beijing. I'd never seen so many bicycles, almost no cars. And when we cycled around Beijing, we only had to worry about other bicyclists. And I didn't see any pollution in the air. I sometimes wonder if adding cars was an advance when they used to have clean air and exercise getting around Beijing. Okay, another fallacy is argument from personal incredulity. This one is pretty ubiquitous. We see it all the time. And this is when somebody says, I just can't imagine that could possibly be true. Now, the girl here isn't buying the argument because she can't imagine it could be true, something that somebody says. Now, again, as I said before, healthy skepticism is a good thing. We're talking about situations where it is not reasonable, but sometimes people cling to their preconceived notions for no other reason than it doesn't sound right to them, even in the face of good evidence. And we all are guilty of this, I have to say. So it's not something that you can point fingers and claim that you'd never do this. So here's a great story. I love this story. Barry Marshall is a physician in Western Australia, and he proposed that peptic ulcer disease could be caused by the organism Helicobacter pylori. Now, the discovery was only made after lab techs failed to clean up cultures. The first 30 tests found no H. pylori. They were culturing the stomach. But lab techs were throwing out the cultures after 2 days. Once they failed to throw out the tests from Thursday through Monday, and they found H. pylori. It turns out they take longer to grow. So it's kind of like Alexander Fleming, who discovered penicillin for the same reason, lack of tidiness in the lab. So being a slob has its advantages. I tried to use this to tell my wife when I didn't do the dishes, but it didn't fly. So in 1983, they sent a paper in to a GI journal, but their results were rejected, and they were told that this paper was in the bottom 10% of all the papers that they received that year. But Marshall was so convinced that he was on the right track that he drank a broth of H. pylori. And it probably wasn't the best idea because he developed nausea and vomiting. And when they did endoscopy, he had massive gastritis. So he got really sick from this. But he was so convinced he had to prove he was right. So he and Robin Warren, his colleague who worked with him on this, eventually published their results. But most people thought he was an idiot. And he was ridiculed mercilessly at gastroenterology meetings for many years as he was proposing this. And I was there. I saw this happen. All somebody had to do was mention Barry Marshall's name, and all these gastroenterologists would snicker and make fun of him. So, and by the way, the Wikipedia entry on this is just wrong. They kind of downplayed this ridicule. I was there and I saw it, and it was pretty bad. So, guess what happened? Marshall and Warren were awarded the Nobel Prize for Physiology or Medicine in 2005. So when I saw this, it became clear to me that all that ridicule was misplaced. I didn't know because this is not my field. I was there to talk about drug interactions. So I just assumed that all these eminent gastroenterologists were right and Barry Marshall was an idiot until I saw this. How sweet that is. So another example of argument from incredulity is what caused the scablands in eastern Washington. J. Harlan Bretz actually taught in a Seattle high school and at UW, and he got his PhD from the University of Chicago, and it only took him 2 years, so a pretty smart guy. He proposed that the scablands were caused by a gigantic flood, and his fellow geologists thought this was the dumbest thing they'd ever heard. So he was ambushed by 6 of his geologist colleagues at a meeting in 1927 who, again, ridiculed him for this dumb idea. But then another geologist, J.T. Pardee, gave Bretz the key insight. There was an ice dam that burst near Missoula, causing a huge flood. And finally, in 1940, started out in 1927. In 1940, Pardee presented a paper about this ice dam, and then more evidence came later from like satellite photos and that kind of thing. And in 1979, at age 96, he received the Penrose Medal from the Geological Society of America. Now, the Penrose Medal is the highest honor the Geological Society can present. So somebody, after he got the medal, they said, how does it feel after all this ridicule? And he said, great, but all my enemies are dead, so I have nobody to gloat over. So he still had a sense of humor about it. And by the way, geologists have a bad track record on argument from incredulity. Plate tectonics is another example that it took decades for them to finally admit that that was going on. And one of the more famous climate change deniers is a geologist. Now, I'm not picking on geologists here because all fields have problems with this. Okay, another one, similar but not exactly the same, is appeal to ignorance. You say, well, X is false because it's not been proven true, or the opposite, X is true because it has not been proven false. And this actually happens fairly often as well. Now, one we talked about already, is there life elsewhere in the universe? Well, you could say, well, it doesn't exist because there's no proof that it does. Or you say it does exist because there's no proof that it doesn't. Both of these are wrong. We don't know, and we should base our choice on probability. And the probability is that it probably, there probably is life. And I don't know if it won't look like this cute little guy, but the question is it plausible? Because absence of proof is not proof of absence. And it is indeed plausible that there's life out there. I don't know how much intelligent life, but it is extremely plausible. So you can't really say one way or the other, but just say that it is plausible, so it may well be true. Another example from a non-scientific perspective is what Antonin Scalia said about executing the innocent. He said, there's never been a single case, not one, in which it is clear that a person was executed for a crime he did not commit. Now, this is absurd on so many levels, it's hard to know where to start. First of all, when he says it is clear, he seems to be saying certain. But that's an impossible standard to ever meet. It isn't absolutely certain that Scalia never committed murder. So what this means is that even if we executed somebody who was probably innocent, or even very likely to be innocent, Scalia wouldn't count them. And there have been lots of cases like that. So that's point number one, is saying that it has to be clear that they are innocent. The burden of proof should be on them rather than the person saying they didn't do it. Would any person who is considered certainly innocent be executed? If it were clear to everyone before execution that a person was innocent, they wouldn't be executed unless they were framed or something. So that's also a reason why that doesn't make sense. And finally, and probably one of the most important, after execution, efforts to prove innocence are almost always stopped. So there are so many probably innocent people on death row that all the efforts are focused on them, not somebody who's already been killed. So if you look at the empirical evidence, it really lends more, puts more shade on Scalia's argument. At least 200 people sentenced to death have been exonerated and released for reasons of innocence. Now, it was 200 people a few weeks ago when I last checked. For all I know, it's up to 201 or 202 because it continues to happen regularly. Now, let that sink in for a moment. That means 200 juries deliberated and decided an innocent man was guilty. Well, usually man, innocent person was guilty, and they deserved to be killed by the state. Now, if this were a rational decision, we would have abolished the death penalty after the first 3 or 4 exonerations. We would have realized, hey, this is a very flawed system, and so we probably ought not to be doing this. So hundreds of innocent people are exposed to the risk of execution, and to think we catch them all before execution is just absurd. Another way to look at it is for every 8 people executed in the United States, 1 person on death row has been exonerated. So we have a serious problem of false convictions sending people to death row. So what is the likelihood that the innocent people are executed? I would put it in that second level, virtually certain. It's not certain, but it is virtually certain. That's what the empirical evidence and reason would suggest. But death penalty proponent Robert Blecker says the likelihood that an innocent defendant will be executed is infinitesimal. This is Blecker's appeal to ignorance, but it goes against evidence and reason, as I mentioned. So I would go so far as to say this is just wrong. What do we actually mean when we use the word infinitesimal? Well, let's look at that. The likelihood I will be hit by a meteor is infinitesimal. It's not 0, but it's pretty close to 0. The likelihood I will do an Ironman is infinitesimal. Again, not 0, but even closer to 0. It's not going to happen. So, but the likelihood that innocent people have been and will be executed is virtually certain. To deny this is to ignore the evidence. And by the way, the reason I know my doing an Ironman is essentially impossible is that I did do a sprint triathlon to celebrate my 80th birthday a year and a half ago. Clear evidence that wisdom does not automatically accompany getting old. I finished, but it was brutal. Ruth added this little stunt to her to volume 4 of her Dumb Things Phil Did. The only good thing was I won my age group because I was the only contestant over 80. So now I'm training for a shorter, less brutal triathlon this coming summer of 2025. We'll see how that goes. Now, experts are usually more right than non-experts, but you have to choose the right experts. This is the key problem here. People can sometimes choose experts who aren't expert at all. Now, we don't have oracles anymore who know everything. Well, I guess maybe AI is the new oracle, but this is the Temple of Apollo in Delphi, where in the ancient Greece, where the Oracle of Delphi did her thing. She was a priestess who claimed to deliver prophecies from the Greek god Apollo. So if you want to find out what was going to happen, like in a battle, upcoming battle, you just consult with her. But it's clear that this does not. Let me read this first. Serotonin syndrome may occur with Imitrex tablets, particularly during co-administration with selective serotonin reuptake inhibitors. This is from the latest version of the Imitrex product information. So, it's clear that this does not happen in the vast majority of people, but the myth persists and it seems very hard to kill. Let's look at the history of this thing. In 2006, the FDA warned about this, serotonin syndrome with triptans and SSRIs. A year later, I wrote a Pharmacy Times column and said, the evidence isn't there to suggest this actually happens. 2010, the American Headache Society position paper seriously questioned the validity and implied basically it doesn't happen. And finally, the coup de grace in 2018 JAMA Neurology paper, an epidemiological study of almost 20,000 patients on SSRIs or SNRIs and triptans, they found basically no evidence of an interaction. So when are we going to drive a stake through the heart of this misconception? Now, I have it on good authority. That's how we're supposed to get rid of vampires, a wooden stake through the heart. But so there are other ones that where authorities have misled us. This issue has been debated since the early 1970s. Empirical evidence suggests that some antibiotics may impair contraceptive efficacy. And here we're talking about oral hormonal contraceptives, estrogen, progestin contraceptives. But yet most product monographs and online sources in the U.S. do not mention this interaction. And many sources now, these days, claim that this drug interaction has been debunked. But the amount of misinformation has been just staggering. So quick history again. Started actually in 1972, where the first reports of unintended pregnancies began to be reported. And it kind of oscillated back and forth where people thought it was real, not real, real, not real. But in 2009 and again in 2015, the WHO declared there was no need, that this interaction was not real. 2010, the U.S. Center for Disease Control agreed there was no interaction. 2011 and 2017, the UK Royal College of OBGYN said there's no interaction. And in the U.S., no warnings in package inserts for hormonal contraceptives in 2020. Now, even sources like Up to Date basically say there's no problem. Now, Canada does not agree, and they do have information in their products. Now, Yasmin for the U.S. does not have any of these warnings. So it can vary depending on the country. But I did some very recent, just this was a few days ago, a Google search of do antibiotics inhibit efficacy of oral contraceptives? And this one said, nope, antibiotics like amoxicillin won't change the effectiveness of your birth control. Rifampin is the only one that does, and that everybody agrees on. So unless you're using one of those birth control methods and taking rifampin, you don't have to worry about it. Same thing, and this I did 2 days ago. I Googled again. You may have heard that if you take antibiotics with your hormonal birth control pills, patches, shots, implants, or vaginal rings, it can raise your chance of getting pregnant. With one exception, rifampin antibiotics. This is a myth. I don't hear this bit of folklore as much as I did when I started practicing medicine, but it's a misperception. So they're calling it folklore, a misperception, and this was a associate professor of OBGYN. So first of all, there are a lot of problems with this statement. Nobody said that patches and shots and implants, vaginal rings interacted. Nobody said that. But even if you just look at the pills, this is not a true statement. So they are accepting. The problem is that none of these people that on the previous slides and on this slide have actually analyzed the data. They are relying on the word of authorities who also haven't read the data. So it's the blind leading the blind. That's probably not a good thing to say, but anyway, it's people who don't know anything consulting with other people who don't know anything. And for some reason, I'm not sure why the debate hasn't changed since 1920, because in 1920, Aronson and Ferner, and Aronson is one of the most respected clinical pharmacologists in the world. He's an MD from Oxford, and he did a very careful report looking at reports to the UK Medicines Regulatory Agency, many thousands of reports. And what they found was reports of unintended pregnancy were higher in patients on antibiotics or enzyme inducers. You see the green one, these were people on control drugs where they didn't expect anything. Antibiotics, the odds ratio was 6.7. and enzyme inducers like rifampin 13. Now everybody agrees on that red column. Nobody disputes that. If you give enzyme inducers, it reduces the efficacy of oral contraceptives. But almost more important than these results, these results don't prove there's an interaction, but they certainly make it at least possible. But the E supplement was one of the most important aspects of this study because they assessed virtually every study that has ever been published on this interaction and critiqued it. So what they basically found was that the vast majority of these studies had serious flaws, invalidating flaws, things that would cause the paper to be a failed study rather than a negative study. They used various antibiotics. Some studied all antibiotics, some studied just certain antibiotics, some studied just one antibiotic. The contraceptive studied varied by dose and route and type of estrogen, progestin. Some included 3A4 inhibitors, which would be expected to increase serum concentrations of hormones, not decrease them. So there's no way that those antibiotics that were 3A4 inhibitors would be expected to interact. If anything, they would increase the blood levels of the contraceptive hormones. Now, antibiotics differ in their antibacterial spectrum and their effect on gut flora, which is the supposed mechanism for this interaction. So looking at all different types of antibiotics, it doesn't make any sense. And most of the pharmacokinetic studies were way too small to detect the interaction, which probably occurs only in certain susceptible women. So all in all, the studies that were theoretically negative, there were errors in virtually every one of them. And assuming you can't do a randomized controlled trial of this, it would be totally unethical, so it'll never happen. But assuming that randomized controlled trials are the only kind of evidence worth looking at, of course, it doesn't make sense. This is Naomi Oreskes' methodological fetishism, a term she coined. So, we're in the home stretch here. Sometimes you do have to rely on authority, and here's an example of that. There was an article in the Peninsula Daily News that I used to get when I lived up on the Olympic Peninsula. And by the way, it was daily news, but it only came out 6 days a week, but that's another story. And the title said, "Rocketeers Hope for Liftoff in May." And they showed a picture of the Rocketeers, the two guys designing the rocket there on the right. And they wanted a passenger who would go up in their rocket. Now, they're from Forks, Washington, which is a population of about 3,500 people. Now, I don't know how many people would be willing to be shot into space by these two guys. I'm sure they're very smart. I'm not doubting that. But anyway, it turns out that my next door neighbor, it just so happens, was John Fabian, who was an astronaut. He went up in the space shuttle twice. So I thought he would like this. So I emailed him the article, and I said I was thinking about signing up to be a pilot of this rocket. His 3-word response in bold, all caps was, "Don't sign up." So John discouraged me from doing this. I was about ready to do it, but he said, "Don't do it." And here's a picture of John in the upper left. He was the scientific member of the crew. He has a PhD in aeronautical engineering from UW, actually. And he was on the woman in front of him is Sally Ride, the first woman astronaut. He was on that mission. And he's a great guy. I really enjoyed getting to know him. Lived next door to him for a long time. So that concludes part 1 of common fallacies and reasoning errors and how to avoid making them. Thank you for your attention.